Welcome everyone to the Aplastic Anemia and MDS International Foundation Phoenix, Rochester, and Jacksonville Mayo Clinic conference in partnership with our wonderful friends at the Mayo Clinic. I'm Lee Clark, Director of Patient Services, and I'd like to thank everyone for attending the conference. This will be a day of learning and supporting patients and their families with aplastic anemia, MDS, AML, PNH, and related diseases. AAMDSIF is pleased to be able to offer expertise of medical experts who will share the latest on disease and treatment information. Each presentation will include time for questions and answers, and you're encouraged to bring your toughest questions to our wonderful medical experts. We would like to thank the corporate sponsors, Alexion, Apellis, Amogen, Bristol Myers Squibb, BioCrest, Genentech, Novartis, Tahoe Oncology, Regeneron, and Servier, and the generous support of the patients, families, and caregivers who without their support, this program would not be happening today. In your conference bag, you will find a folder with the program schedule, with a notepad and some other things that we thought that would be helpful for you throughout the day. If you're interested in one of our patient toolkits, in your folder, you'll see that there is an order form. If you take some time to fill it out, please give it to everyone at the registration desk. We will be happy to send you the toolkit by mail. Today can be a very long day for everyone, so please do take care of yourself. And if there's anything that you need, please let one of the staff know. We're here to help this day be a success for you as patients. Before we get started, I'd like to thank our wonderful conference chairs for working with us for many, many months and putting together an amazing team of medical experts. This is a one-of-a-kind conference, and AAMDS would like to thank all of our wonderful medical chairs. Doctors James Fornan, Hemant Murthy, Cecilia Ariana Yee, Nandita Kara, Arif Al-Khalai, and Hassan Al-Khatib. Additionally, we would like to thank the wonderful support staff at Mayo Clinic, this would not have been possible without their assistance. So to Christina, John, Myra, Carol, and Pam, thank you for all of your hard work behind the scenes. To the AV teams, Lonnie, Michael, Chris, Josh, Eugene, Tyler, and Kevin, thank you very much for putting this together so those of us who aren't able to join us are able to participate in the day. To begin the conference, I'd like to introduce Dr. Nandita Kara, and then I'd like to introduce, for our first speaker would be Dr. Cecilia Ariana Yee. Dr. Ariana Yee is a senior associate consultant and the director of the leukemia services here at the Phoenix Mayo Clinic. Her clinical and research interests focus on acute and chronic leukemias, myelodysplastic syndromes, and myeloproliferative neoplasms. At the end of Dr. Ariana's session, we will be taking questions from the audience and question online. We'll be going back and forth between Phoenix, Rochester, and Jacksonville, so the staff in the rooms will be able to help you with asking questions. Please wait for the staff to bring a mic. That way, everyone in each location will be able to hear what is being asked, and those online will be able to hear your questions as well. Thank you. Dr. Kara, did you want to say hello before Dr. Ariana Yee is here? Come on up.
I would like to welcome you all to this day of learning. As Lee said, it's been a pleasure organizing this, and I hope you can get some good information to go back today. Thank you.
With that said, we'll go ahead and get started. Welcome, Dr. Ariana Yee. Thank you so much for the presentation today.
Good morning, everyone. I am really honored to be the first speaker in this group of sessions in collaboration with the Plastic Anemia and DS Foundation. Welcome for all of the attendants in Phoenix, as well as in Rochester and in Jacksonville. And I hope the weather in Jacksonville and Rochester is as great as how the weather is today in Phoenix. Thank you very much for everything, and thank you so much for the kind introduction, Lee. I'm going to start with the first topic of the day. It's going to be a topic that is relevant for the purpose of raising awareness for patients with low blood counts, specifically because there is a number of medical conditions that we're going to talk today that are very relevant for the evaluation of the patients and, more importantly, for treatment options. We're going to review two cases that we have seen in the clinic. Obviously, I'm going to change the names of the patients. Two cases specifically. Two young men that don't have necessarily the same disease, but we're going to review about some similarities and particular details that could potentially lead to the right diagnosis in those patients. The first patient is a young man, younger than 30 years old, with history of anemia for a number of years, with a recent diagnosis of myelodysplastic syndrome, who is in preparation for bone marrow transplant. What is particular about this patient is that now, compared to years ago, he does have symptoms, and many of the symptoms are symptoms that many patients do experience when they have blood disorders. One of them is the lack of energy. This is primarily one of the most common symptoms that patients recognize, followed by changes in the appetite, weight loss, and more importantly, predisposition for infections. Something that is typical, characteristic for this case is that there is a premature gray hair, but it's obviously very subtle, even the patient does not recognize that. And in the family history, remarkable for the mother who had liver disease and died of liver problems, and a relative, first-degree relative with history of low blood counts. On the right side, we have the pathology information that shows some changes that are ongoing in the bone marrow. And the case number two is another patient with a history of low counts, specifically low red cell counts and low platelet counts, anemia and thrombocytopenia. What is different from this case compared to the other is that there is history of abdominal symptoms. These symptoms were more prominent during the childhood, diarrhea, bloating. So this patient has history to follow up with the pediatrician and to have follow-ups with the gastroenterologist. The family history, remarkable for a young brother with acute myeloid leukemia, and the bone marrow biopsy show some characteristics concerning for this medical condition called myelodysplastic syndrome. The chromosome analysis remarkably show a piece of the chromosome 20 missing. So these two examples are cases of a group of disorders called bone marrow failure syndrome. We would like to start with definitions. The particular group of disorders that I'm going to focus today are the inherited ones, the ones where patients were born with a genetic abnormality and eventually over time, when they become young adults or adults, is where they start to develop symptoms. We're going to talk a little bit about genes, and I just took this cartoon because there will be comparisons between those who carry mutations versus those who don't carry mutations. So let's start with the basics. Bone marrow failure is specifically meaning that there is not good production of blood cells. So if we talk or compare the blood cells produced in the factory of the blood cells, which is the bone marrow, that is in the right side of the cartoon, the bone marrow is the factory of the blood cells, where they produce, or the stem cells are localized there, and the stem cells are the parents of all of the blood cells, where we have down there in the imaging the production of red cells, white cells, and platelets, which are important cells for us to live. What happens in bone marrow failure is that for some reason there is a defect in the production of those blood elements, for which the patients can show up to the clinic with the 3 blood counts that are low and that's what I am showing, the arrows showing low numbers, or a few of them, one of the cells, for example, anemia only, or low platelets, but eventually in the end, all of the three blood elements are in the lower range. And the other important point is in this other right arrow, the capability of these cells to transform to acute leukemia, to transform to blood cancer. Many times we capture those cases before they develop the cancer, but in many others when they already have the blood cancer. What is the incidence of this group of disorders? Is rare, very rare. Just to mention two medical conditions, for example, Fanconi anemia, the incidence is even below 1 million cases. So it's kind of like a winning the lottery. 1 in 1.3 million for Fanconi anemia, and the second group of diseases, which is this keratosis congenita, is 2.5% of the inherited bone marrow failure syndrome. Sometimes we really don't have great statistics because these diseases are rare and many times are associated with significant delays in the diagnosis. And the last point that I wanted to show is that all of these syndromes have the capability to transform to blood cancer. This is a Venn diagram of the different types, classifications of bone marrow failure syndrome. So if you see at the top left, we have the subgroup of the inherited ones. But if you see the other circles, you will have information about the other different medical conditions, where at the bottom we have the most common ones that we recognize: acute myeloid leukemia, myelodysplastic syndrome, a little circle for PNH. We're going to talk about these two important diseases. And then on the right side at the top, we have the immune-mediated cases associated with conditions that could potentially trigger bone marrow failure. For example, those cases who have received in the past radiation treatment because of history of other cancers, chemotherapies, including cell therapy treatments such as CAR T-cell are main reasons for the patients to develop bone marrow failure syndrome, which help us to categorize these bone marrow failures in two important groups. The first group is the acquired bone marrow failure syndromes, where the classical ones are the aplastic anemias, that many cases are idiopathic, which means that nobody knows why the patient develops aplastic anemia, and in others, the ones that are like secondary to history of radiation, chemotherapy, drugs, infections are another remarkable groups. And then the second group of the inherited cases that are born, where the patients are born with the genetic defects leading towards bone marrow failure, and there is a list of those. Again, I'm not going to talk about the different syndromes, only a few of them, such as Fanconi anemia, this keratosis congenita, DDX41 familial MDS-AML. And why this distinction is important? It's not only for the purpose of the doctors classifying disorders, but it has practical valid points. First of all, treatment options. It's not the same to treat a patient with Fanconi anemia than treating a patient with acquired aplastic anemia. Second, because of the counseling. Many inherited bone marrow failure syndromes have inheritance. Many of them are autosomal recessive, others are autosomal dominant, so assessing other family members are extremely important for evaluation of the patients, and more importantly, to determine the risk for other diseases. Why is that? Because these syndromes in general are not only associated with the development of blood cancers, but also other medical conditions, including predisposition for solid tumors. All right. So let's review additional aspects, specifically how we approach to inherited bone marrow failure syndrome, and what are the testing that we need to determine the diagnosis. So this is a table where the purpose is not to memorize all of the details about the different syndromes. In realistic scenarios, this is certainly a longer table, but just to mention a few characteristics, specifically regarding clinical features, the genetics of those disorders, and the pathophysiology. As you see, the different syndromes don't necessarily have the same clinical features, the same as the genes are not the same, for which the physiopathology is not the same as well. And why I am bringing this table? First of all, because for the right diagnosis of these patients, we need to have very high index of suspicion. First of all, because these are rare disorders. Routinely, we don't test patients for this. Second, because once we think, doing our detective work, of some syndromes, for example, the two cases that I presented at the beginning, we need to develop a plan, our strategy, how are we going to approach this case. And finally, confirm our thoughts with the right genetic testing. So these are primarily the 10 important principles when we approach this different group of disorders. Whom to test? Certainly, we don't need to test everyone for inherited bone marrow failure syndrome. As I mentioned, these are rare medical conditions. And for that, to answer this question, we certainly have the guidelines that help us to determine which diseases, which patients we should test. The National Cancer Center Network recommends testing for IBMF, the following groups. First of all, the patients with newly diagnosed aplastic anemia, and we have in our clinic a number of patients per year with this diagnosis. Second, testing all patients younger than 50 years of age with diagnosis of acute myeloid leukemia or myelodysplastic syndrome. Ideally, all of these patients, adults, young adults, and below the age of 50 should be tested for that. Next, patients with history of genetic predisposition syndrome. Obviously, the patients who have history of Fanconi anemia or a relative with Fanconi anemia ideally should be tested for that. Those with a rare subtype of myelodysplastic syndrome, specifically myelodysplastic syndrome with very low cellularity, as documented in a regular bone marrow biopsy, and then potential transplant donors. Specifically, we see in the clinic a patient that is in preparation for transplant. One of the big questions that we always ask is the status of the donor. If we are considering related donors, for example, donors that are siblings of the potential patient, we assess then for the possibility of acquiring or having genes that could potentially be detrimental for the patient outcome if the patient gets a stem cell from somebody with this inherited bone marrow failure syndrome. How do we do the evaluation? Is a routine set of studies. First of all, and this is very important, the history and physical. There is nothing that replaces outstanding physical examination, history that is remarkable for cancer in the patient or cancer in other family members, physical examination to look for some anomalies that we can identify in younger patients with inherited bone marrow failure syndrome. This testing is complemented with laboratory studies. I mean, all of you are familiar with laboratory studies, starting from testing such as blood counts, blood smear, evaluations for other reasons for cytopenias, evaluation of the liver function, testing for PNH, and there will be sessions about these topics in the next hour and so. The diagnostic confirmation of the medical condition with a bone marrow aspirate and biopsy. Very likely a number of you already had a bone marrow biopsy. Then the studies are complemented with functional assays for evaluation of the different types of inherited bone marrow failure syndrome, and finally, germline analysis. The germline testing is the testing that we do to confirm the gene that is affected in the inherited bone marrow failure syndrome, and HLA typing, which is part of the routine assessment, given that many of these patients get benefit with transplant. How do we do the functional assays and the genetic testing? I just mentioned a couple of those. For example, for this medical condition called Fanconi anemia, there is one testing that is called chromosomal breakage testing, and it's a testing that is done in some academic institutions. Then for short telomere syndrome, or where the dyskeratosis congenita is coming from, this study called telomere length analysis or flow fish. This is the easy way how to ask for this testing. And then I mentioned 4 different centers that are in charge of doing sequencing for germline mutations. I just mentioned a few. Cincinnati Children's Hospital, where they have like panels. Some of these panels have different types of genes for different types of bone marrow failure disorders, Invitae, ARUF, GeneDx, and according to the disease that we are thinking about, we can order those potential panels. Certainly, this testing assessment is not easy. Many times we have the help and the support from the clinical genomics office, where they are basically the experts in identifying potential inherited diseases in a number of patients, including patients with inherited bone marrow failure disorders. So regarding a few of these medical conditions, I would like to start with this group of disorders that are very interesting, and let me tell you, I'm very proud to belong to this organization, Mayo Clinic. Rochester is certainly leading the research in telomere biology diseases. One of them is this medical condition called dyskeratosis congenita. I already mentioned at the beginning how frequent is this disease is rare, specifically this genetic condition, where what is particular about this disorder is that in addition to causing low blood counts, which is half of the patients, there is another group of patients that do not have bone marrow failure. They have other clinical manifestations, and in fact, they are not seen by hematologists. They are seen by the lung doctors, by the liver doctors, and not necessarily the index of suspicion needs to be addressed by the blood doctors, just to mention how complex is this group of disorders. There are approximately 18 genes associated with telomere biology diseases. Some of them are affected in dyskeratosis congenita. I showing you the different organs and systems that are involved. Interestingly, practically a number of these patients have some clinical features, for example, premature hair graying. This might be a little bit difficult, especially because of women tend to have, hair dyes at a younger age, but it's one of the typical presentations, specifically in adults or young adults. In children, in general, we can consider certain characteristics that could be particularly concerning for dyskeratosis congenita, but my focus will be how to identify these medical conditions in adults. And the primary concern in many cases for which patients get referred to us is cytopenias. Low blood counts that are unexplained by other reasons for that. Other group of patients can have idiopathic lung problems, for example, pulmonary fibrosis causing shortness of breath and cough. Others can have liver disease that is cryptogenic or idiopathic. The testing that we do, which is the functional assay, is the flow fish or the telomere length by flow, and in general, the confirmation is with the germline mutation. On the right side, and this is a review article from one of my colleagues in Rochester, Dr. Mangokar, is a summary of the different locations of the telomere biology complex. The telomeres are part of the extension of the chromosome, kind of in the extremes of the chromosome, that are part of the genetic material that helps the chromosomes and the cells to stay stable over time, to prevent chromosomal instability and predisposition to develop a number of medical conditions. I'm not sure if you have watched in videos or in the TV about telomere and aging. There are a number of concepts behind this, because with aging, we start noticing defects in the production of telomeres, causing shortening of the telomeres. And as a consequence of that, for all of us as animals, human beings, to have a number of problems associated with aging, such as increased frequency of cancers, a number of medical conditions that potentially are associated with decreased survivals. On the right side, we have a number of genes that are associated with this keratosis congenita in the different complex of the telomere synthesis. I just want to show, for example, this one, the sheltering complex, the telomerase trafficking, where this keratosis congenita is involved, and then other complex. So it's not one gene that we are talking about. We are talking about different locations of the genes. Therefore, it is important to always confirm our suspicion once the assay, the telomere length, is abnormal with the genetic information. This is an example of the flowfish, where in the upper part, talking about the first row, we have what is normal, the lengths that are in the 50 percentile in the lymphocytes and granulocytes on the right and the left. And at the bottom, we have a testing that is abnormal, which is in the 1 percentile of the telomere length. So this result is positive, and this result implies that we need to confirm this with the appropriate genetic testing. Right? Fanconi anemia is another important disorder that is part of the inherited bone marrow failure syndrome, where this syndrome has been classically defined as a chromosome breakage syndrome. And why is that? Because many studies in the 80s where we exposed the chromosomes of these patients to certain chemicals are associated with the breakage of some of the chromosomes, and that is what leads to the diagnosis of Fanconi anemia. Very interestingly, this Fanconi anemia has predisposition not only for hematologic malignancies, which are the reason for this talk, but also to other cancers. And I would say the predisposition is 50-50. Squamous cell carcinoma, talking about head and neck cancer. This is a cancer that my colleagues in medical oncology see quite often. And from our side, predisposition for hematologic malignancies. Interestingly, and this is a typical slides that I see from my pediatric hematologist colleagues, they love putting pictures of different patients with different anomalies. Unfortunately, in adults, we are not going to necessarily see the classical clinical manifestations that I put on the right side in red, the café au lait spots, microcephaly, developmental delay, or short status. Many of the Fanconi anemia that are going to show up to our clinic are going to be like you and me, without any issues. We might identify some skeletal abnormalities, but at first assessment, we might not notice anything in them. Half of them are like that. And what is remarkable is that they have low counts. Many of them are already transformed to leukemia. And similar to this keratosis congenita, there are like different genes. So it's not only one gene that explains the syndrome. There are like approximately 23 genes explaining that. The most common genetic changes are related to FANCA gene, which is autosomal recessive inheritance, followed by FANC in 8% and different other genes associated with Fanconi anemia in 27% of the cases. So that is why it's very important to do the appropriate genetic testing, not to miss the diagnosis of Fanconi anemia. Are there functional testing? I already mentioned that at the beginning. This is a typical chromosome fragility testing that is done as a part of the routine assessment. This is a testing that is done in some academic institutions, specifically the Cincinnati Hospital, Children's Hospital, where the chromosomes are exposed to these two chemicals, the deoxybutane and the mitomycin C. And if you see in A and B, of the pictures here, the fragility of some of the chromosomes, giving us a positive testing. Again, this testing is not 100% sensitive, but if the testing is positive, the testing needs to be automatically confirmed with genetic confirmation. These are different panels. I just mentioned one, the panel at the bottom that mentions, evaluates different genes, are a panel from one of the commercial labs. This is ARUP. But in general, the techniques that are used to identify genetic changes related to germline mutations are through massive parallel sequencing. What is the sample? This is not the typical bone marrow aspirate sample or the blood sample that we do for the regular assessment of bone marrow biopsies. In general, the preferred testing for germline mutations is the skin, the cells of the skin, the fibroblasts, through a skin biopsy. That is the standard way how to send samples. Many times when I work with clinical genomics, the genomic doctor orders a panel in the blood, but specifically when we had patients with blood disorders, we really don't recommend assessing the blood. Why is that? Because those patients in general have acquired mutations. Acquired mutations means that they were not born with those. They acquired the mutations, and many times those mutations are responsible for the blood cancer. So if we have a genetic testing in the blood, we might overlap results that are particularly in the bone marrow biopsy for acquired mutations, and we might not necessarily capture the mutations that are the ones that we want to search, which are the germline testing. That is why when we evaluate a patient for these disorders, in general, and this is my approach, I ask the clinical genomics doctor to evaluate the patient and to order the skin biopsy for the fibroblast culture. Rochester has a different approach that requires validation, which is the not the fibroblast, but the hair follicle, where they remove a little bit of hair from the regular hair, but also from the eyebrows, just to culture those cells and to do specifically the same group of genes. So let's continue with the cases. I already mentioned the case number 1. The biopsy in this case show myelodysplastic syndrome, but what was particular was that the cellularity of the bone marrow was decreased. So that's why you see in the picture on the right side decreased cellularity. The chromosomes were otherwise normal. The NGS that I mentioned here is the genetic search in the bone marrow for somatic mutations, talking about the mutations that are acquired, all right, that are part of the standard. So the NGS didn't show any changes. But because of the suspicion, given the family history, the gray hair at a young age, the patient ended up having the functional testing, which is the flowfish, that was positive. And the telomere length was less than 1% percentile. And given this information, the doctor treating the patient proceeded with ordering the germline testing, and the patient had third mutation. Can you guess what the diagnosis is? no need to. The diagnosis is concerning for dyskeratosis congenita. Third is a genetic change that happens in patients with the spectrum of short telomerase syndrome, which is dyskeratosis congenita. Right? There is another syndrome that is called SDS, right, or Schwann-Diamond syndrome. I'm not going to talk too much about that, but we talk about, we have a case recently in the clinic with my colleagues from classical hematology. This is a disorder of the ribosomes. The ribosomes are structures that are in charge of the assembly of the RNA, and is associated with mutations in this gene called SBDS. Many of the cases that we see, and this is again a very rare disorder, have low blood counts, and this is many times the reason for consultation. They have a history of problems in the pancreas, as well as predisposition for infections. Many of these patients have stomach symptoms and the classical steatorrhea. And in the chromosomes, the classical finding is to have this piece of the chromosome 20 missing, as well as this special configuration of the long arm of the chromosome 7 called isochromosome 7. And these patients have a high risk for MDS and AML. This patient, the case number 2, had in the molecular panel in the bone marrow, TP53. He started conventional chemotherapy and was in preparation for transplant. Since there was a high suspicion for something wrong in the inherited bone marrow failure syndrome, the patient had the mutation panel that was positive, and this is at the bottom, for SBDS, which is the genetic confirmation for Schwann-Diamond syndrome, and the diagnosis got confirmed. On the right side, this is a large case series from last year, published in 2022, about the survival over time of those patients. So if we see at the bottom, the survival in years, when we made the diagnosis in the age of 30, 40, the survival is certainly a lot more shorter. That is why it's very important to determine the diagnosis right on time. This is an important concept that I mentioned at the beginning, the transformation of inherited bone marrow failures to leukemias, where for some reason, and this is at the bottom row, patients with these mutations, inherited bone marrow failure syndrome mutations, carry clones, which are acquired clones, somatic genetic changes that eventually over time tend to expand and produce the clinical manifestations of leukemia. All right? Which brings me to the next point, which is the predisposition syndromes that are for hereditary myeloid malignancy. The inherited bone marrow failure belong to a small group of these patients, but there are approximately 23 gene syndromes that are reported in the literature and then are already mentioned as a part of the NCCN guidelines for identification and management of those patients. Who do we need to test for this group of patients? The answer to that question is on the right side, where Lucy Godley, one of my female heroes, evaluated in patients at all ages, from 0, 80 years old, the percentage of germline mutations in population with blood disorders, blood cancers, and the answer to that question is that she found that approximately 7% of all ages had germline abnormalities. Therefore, she considers that everyone ideally should be tested for germline mutations, no matter what the disease is, but it has to be something that ideally we should screen more often, right? And with this information, she comes out with different distribution of ages. For example, in young adults, different syndromes, Fanconi anemia in young adults, short telomerase syndrome in young adults, and in older adults, DDX for one. And you see the distribution of the different variants, germline variants. One of the most common one is DDX for one. This is a syndrome that has been evaluated over the past 10 years, where patients had predisposition for leukemias, where what is particular about this disorder is that patients older than 50 years of age with AML, MDS tend to fit into this category. What is particular about DDX41 is that approximately a third of these patients are not going to have family history of blood cancers. That is a very important information to keep in mind. The majority of the patients are male, and in general, the somatic testing that we do through the standard bone marrow biopsy molecular panel is able to identify these mutations that in general do require a confirmation with germline testing. The testing is again ideally in skin fibroblasts, and there is a panel that incorporates DDX41. On the right side, there is the functionality of the DDX41, why it's important. It helps to keep the stabilization of the RNA. So when patients had mutations in DDX41, this RNA is unstable, and as a consequence of that, there is a dysregulation in the immune system, so the capability of fighting against abnormal cells gets low, and as a consequence of that, patients have the capability of evolving to blood cancers. How do we approach this? And I'm going to finish in the next 2 minutes. We have the suspicion, clinical suspicion, followed by functional testing. The first studies that we do for Fanconi anemia are the chromosome breakage and the flow fish for short telomerase syndrome, especially in young adults. This confirmation is through skin biopsy. And then we do the NGS in the bone marrow, but in parallel, we consider the genome sequencing for germline mutations. What are the challenges and opportunities? I would love having a right answer to the question and making things very easy. These are the challenges and opportunities. First of all, what I say at the beginning, not all patients are evaluated for these disorders. Therefore, ideally, we should expand the search to different group of patients. Transplant is a curative option. I will talk about transplant in a moment. And the million-dollar question is when to transplant these patients. What is the optimal timing for that? This group of patients tend to have a specific sensitivity to chemotherapy, for which we need to have ideal treatment selections. And then in preparation for transplant, specific trials or drugs that are ideal for preconditioning, improving the treatment outcomes and survival. The final slide are related to clinical trials. There are not a lot of them. The group of studies that are ongoing are primarily evaluating the natural history of this disorder, information about the genomics of these disorders, and optimization of transplant options. There are some examples here. There is a study where Mayo Clinic is participating, the radiation and alkylator-free bone marrow transplant, where patients have a special conditioning where they are not exposed to radiation or alkylator agents that right now are showing improvement in the survival outcomes, especially in this keratosis congenita. The second study is a study conducted by NIH to evaluate other cancers in inherited bone marrow failure syndrome, not only blood disorders. And the final is the one that Mayo Clinic Arizona is participating, which is the premyeloid cancer and bone marrow failure clinic study. I'm not sure if some of my patients are already present here, but we have this in the CHIP clinic, which is a clinic that we have over the past couple of years. In conclusion, these are rare disorders associated with low blood counts, increased risk for hematologic malignancies. The recognition is in patients with low counts or patients who already have established MDS AML. Transplant is curative. The diagnostic workup involves functional assays confirmed with germline mutation analysis, and finally, clinical trials that are needed to improve patient outcomes. Thank you very much for your time, and I'm happy to answer any questions.
Thank you, Dr. Ariane. We'll go ahead and take some questions, starting here in Phoenix. Nikki's gonna take care of that, and then we'll go to Rochester and Jacksonville. Just a moment. And if everybody could make sure that if they have questions, that they ask in the microphone, that way our other locations can hear, and anyone online can hear as well. So just a moment, thank you.
So do we have any questions from anyone in the audience at all? Okay, well, in that case, I'll shoot it over to Rochester. In Rochester, do we have any questions?
No. Oh, yes, one.
Hi, Cecilia, this is Arif. So if somebody has a concern about the possibility of inherited marrow disorder, how can he get to one of these access clinics? Can you hear us, Dr. Irina Yi?
Yes, yes, I hear.
Oh, my question is, let's say there's a patient who is concerned that they may have inherited MDS. How can they get that extra workup done? Because I think these clinics are not available everywhere.
Thank you. Thank you very much for your question. Well, I am glad that because of the increased awareness of this disorder, patients start to consider the possibility of inherited disorders. One of the most important triggering points specifically is, as I mentioned, increasing the rise of suspicion. Specifically, there is history of other family members affected by blood cancers. If that turns to be the case, it's important to bring this information to the doctor. Now, once this information is completed with the physical examination, what we do is to proceed with the evaluation, the regular evaluation with blood counts and a confirmatory bone marrow biopsy. If there are still concerns for inherited bone marrow failure syndrome, we complement the testing with functional assays. We try to identify the most common ones, for example, short telomerase syndrome or Fanconi anemia, and we proceed with those functional assays. If those are positive for either one or the other disorder, in general, we proceed selecting a germline mutation panel. And this is in general something that we work together with the clinical genomics office, where we try to select the best panel that could match with the clinical history, family history, and bone marrow biopsy results. And this is the way how we standardly approach this. Now, an important component of the assessment is not only the information that I would like to say, but the germline mutation analysis many times requires insurance approval. And this is something that unfortunately not all the insurance can cover, for which it's important to review with the patient about the cost of the testing. But once the testing is completed, then review the potential approaches or treatment options. Did I answer your question?
Yes, I think you did. And I'm going to shoot it over to Jacksonville. In Jacksonville, do we have any questions?
Yes, two statements and one question. First of all, the weather in Jacksonville is 80 degrees and bright sunshine, so we may be better than Phoenix.
Yeah, we are kind of comparable.
Second point, in your Fanconi anemia discussion, I didn't see any mention of my understanding is that it is almost predominantly for African Americans.
Thank you. Thank you very much for that information. We still don't have much data about the distribution according to ethnic background or of certain diseases. That is why the NIH is currently working very hard on obtaining registries for the distribution of these rare disorders in patients with different backgrounds. We still don't have that information, unfortunately. As I already say, these are rare disorders, but what is the real distribution of Fanconi anemia or other inherited diseases in other patients, Hispanics, African Americans, is still not known.
My question relates to aplastic anemia. You had a slide that said aplastic anemia inherited. was tied to the DDX41 gene. In acquired aplastic anemia, would that gene identification be of any value in deciding on a treatment?
Yes, DDX41 is usually associated with AML and MDS. I wouldn't be surprised if we eventually identify aplastic anemias with DDX41, but that is not the most common scenario. Aplastic anemia could be associated with the other different disorders, including short telomerase syndrome, most classically with Fanconi anemia as well. So that is why, as a part of the pre-transplant workup, specifically in young adults, we routinely conduct the testing for those cases. Importantly, DDX41 is associated with leukemia development in patients older than 50 years of age. So if we have a patient meeting those characteristics, then is where we do the assessment for DDX41 syndrome.
We have another question.
Go ahead.
Dr. Rana, your presentation was very nice. It went over my head. I don't have any medical training, so you have to excuse me. I don't know how to phrase my question, but suppose someone is suspected of having PNH. What test you will do on him or her that will make you diagnose without any shadow of doubt that person has PNH? Because it's so rare, 1 in 1.3 million, that's what you said. But a person who has a PNH, that ratio doesn't matter because he got one.
Thank you so much for
That's
your
that's
question.
100%. So my question to you, what if that person came to you, what test would you run on him or her that makes you diagnose correctly, 100%, that he or she has PNH?
Thank you so much. This is a very important question. First of all, there will be a session about PNH in the next hour or so. But just to put it in a couple of lines, the same as the many other bone marrow failure syndrome, the index of suspicion is important. Low blood counts. PNH has a particular scenario where patients can have hemolysis, talking about destruction of the red blood cells, for which many times patients are going to have acute symptoms associated with very bad anemia. Abdominal symptoms, the possibility of clotting complications. So if I have a patient with low blood counts, clinical symptoms that are acute with very bad anemia, in general, I consider the potential diagnosis of PNH. PNH could be associated with aplastic anemia, talking about very low blood counts requiring transfusions. So it's part of the workup that is done routinely in those patients. And the good thing is that the testing is in the blood. So we don't need necessarily a bone marrow biopsy. It's called a PNH flow, where we evaluate in the blood the PNH clones in the red cells or the white cells. And many times we do the confirmation through that.
Thank you, Dr. Iannini. We have a question online for you. This question says, my family member was originally diagnosed with, Fanconi anemia. Then they thought it was aplastic anemia. Now we're back to Fanconi anemia. Are the two diseases closely related? And could it be that the aplastic anemia is really the diagnosis and they think that's inherited as well? How do you know?
Thank you very much. This is a very important question. What is the link? The link is the following. Many times what we diagnose is the syndrome, which is the aplastic anemia. Low production of red cell counts. We do a confirmation with a bone marrow biopsy, and we see very low production of blood cells. So what happens is that very likely Fanconi anemia is the reason, the cause of the aplastic anemia in the patient. So I don't know the case hand to hand, but aplastic anemia workup very likely include Fanconi anemia assessment. And that, in general, require this functional assay, which is called the chromosome breakage analysis, which is the functional testing, confirmed with the germline mutation testing. And that is what confirmed the diagnosis most likely.
Thank you. And we have some more questions from Jacksonville.
Doctor, throughout the morning, I've heard something called, I think, TP53. I guess it's a mutation, and I guess it can be caused by both secondary cancers and just general mutations. Is there any way to isolate it or destroy it or mitigate it or offset that? And by the time you find out that there is a TP53 mutation, is the damage already done?
Thank you so much for your interesting question. The doctors talking about NDS most likely are gonna focus on that particular mutation because and this is for all the audience, when we identify TP53 mutations, specifically these are in many cases acquired mutations that happen in many patients with established blood disorders. I am just giving you a couple of examples: acute myeloid leukemia, myelodysplastic syndrome. These are associated with, in general, poor responses to conventional chemotherapy and not the best responses after transplant. Some inherited bone marrow failure syndromes are associated with the presence of TP53. We still don't know this association. That's why there are a number of ongoing comprehensive genomic studies of some bone marrow failure syndromes, but the typical association, as I already mentioned in the presentation, is TP53 in this syndrome called Schwann-Diamond syndrome, where when the patients already evolve to acute leukemia or MDS, they already have the mutation, and unfortunately, even if those patients are treated with the conventional options, including transplant, the outcomes are unfortunately not the greatest. Now, TP53 is unfortunately one of the major challenges for hematologists and transplant doctors. And the reason for that is because they are classically associated with limited outcomes. There are a number of clinical trials ongoing targeting those particular mutations, but those mutations are quite complex, and we have until now not been very successful in improving responses to those disorders, and more importantly, improving the survival at long term. So we are still favoring in those scenarios transplant options, try to minimize the presence of the clone with chemotherapies, clinical trials, and so, and hopefully we'll find an answer to your question very soon.
Thank you. Another question from Jacksonville?
Doesn't look like we have any right now.
And Rochester, any more questions?
No.
Do we have any in the room at all? What? Okay.
Just a follow-up on the question on PNH. Yeah, I think he asked, is it 100% when you do the test and they test for PNH and they get a result, that is you have PNH? I'm not sure that was answered. You're nodding yes, so.
Yes, the answer is yes. If the testing is positive, I am talking about the assay for PNH by flow cytometry, the answer is yes. Obviously, we need to assess the percentage of PNH clone in the testing. If the percentage is very little, for example, less than 20%, 10%, We don't determine that the patient has necessarily the syndrome, the PNH syndrome. The patient has the clone, but not necessarily the syndrome. The syndrome is the one that I already mentioned, classically is associated with low blood counts, with symptoms of clotting complications, intravascular hemolysis, and so, that require not only treatments with immunosuppression, but treatments that are blocking the complement pathway, improving the outcomes in those patients, preventing more clotting and hemolysis in those patients. But in general, the functional assay is what tells us and confirms the diagnosis.
Thank you so much, Dr. Ariana Yee, for sharing your time and your expertise with all of us today. If you'd like to watch this session again at a later time, it will be available on the conference platform within the next hour by accessing this session, clicking on replay, or by navigating the on-demand tab in the platform hub. For those in person, we will be posting the session on our website, so you'll be able to access that probably in the next 7 to 10 business days. If you have any additional questions, please send it to us at any time in 3 ways. You can email us at help@aamds.org, call our helpline at 800-747-2820, or you can submit your question to our Facebook page. If you're online, take a few minutes to check out the exhibitor hall. Our sponsors have some information there, and you can request to have a chat with them. If you're in person, take some time to visit the exhibitors that are set up where you're at and chat with them. On behalf of the foundation, I'd like to thank you for making us your resource of choice and joining us today for this session. Our medical advisory team and staff are always here to help you and your family, as we've done for the past 40 years. This concludes our session.